Thank you, Esther. Thank you for the kind introduction. As Esther has already highlighted, the topic of today is the importance of clinico-pathologic correlation in skin cancer diagnosis. The skin is quite a large, complex organ, which has a lot of micro structures. I think a lot of us, when we think of the skin, we tend to just think of the epidermis and dermis only, but within the epidermis, there are other cellular constituents such as basal cells, the melanocytes, Merkel cells. Within the dermis, you've got pilosebaceous follicles, and you also have sweat glands, which comprise eccrine and apocrine glands. And underneath, you've got the subcutaneous fat. So for this reason, the malignancies that can arise in the skin, they're actually quite wide. And a lot of them actually, like, we're still only discovering their actual biology. And because of that, I've actually just decided to split the presentation, or rather the topic, into two parts. So today I'll only be dealing with the epidermal malignancies. And if there is an interest, I can actually do the remainder of the talk at a later stage as part 2. So my aim here was actually to foster collaboration between clinicians and histopathologists by highlighting certain clinical pathologic entities and or contexts which can be of benefit to both, to both disciplines, so as to benefit the care of our patients. And I will start with basal cell carcinoma because it's the commonest skin cancer. It's way more common than SCC and melanoma. In South Africa, it's the second commonest malignancy amongst males and the third common amongst females. And in the white population, it is actually the commonest malignancy. And with regards to its presentation, these are usually in the elderly white patients, and the males are affected more than the females, and 80% of these tumors are located on the head and neck areas. And typically what one would see would be this pearly nodule, which is shiny and may show telangiectasia, as in these images here. And sometimes they can be ulcerated. What's on the other side here is just the squamous cell carcinoma. This patient actually had 2 lesions. And sometimes they can be distributed on the legs. In this particular case, the ulcer was actually obscured by the background changes of chronic stasis dermatitis. So for quite a while, it was actually just presumed that this is part of a stasis dermatitis-related ulcer. In some instances, they can form a sinus which extends deeply, such as in this case where it's located on the preauricular area. And in other instances, it can be pigmented. In this particular case, there's clearing in the center, and for that reason, it actually mimics a regressing melanoma. So it's not just melanoma that's pigmented. There's a whole lot of skin tumors that can be pigmented, which include trichoblastomas. Some SCCs can also be pigmented. So it's quite a long list. In terms of the histology, your typical BCC will look like this under the microscope. The nodules of basaloid cells, there might be some areas that are a little bit adenoid, and on the bottom right here is what you actually expect to see in a BCC. Sometimes you can have nodules that are cystic, and hence some tumors will actually appear as cystic lesions because the nodule, or rather the cyst, can be quite big. Now, the morphologic types of BCCs, there's a lot of them. There's at least 20. It might actually even be more than 30 of them. Most of these are not really, of importance in terms of clinical practice, but there are some which are quite important for you to just keep in mind, and I have highlighted those ones, and I will discuss them at a later stage. Most BCCs are locally destructive lesions. Metastases are very rare, in the range of 0.003 to 0.55. And when they do metastasize, about 65% of this will be in the regional nodes. And this tends to be in tumors that are quite large and neglected, located on the head and neck areas. And I actually expected this to be, just from experience and practice, the ones I've seen, they've actually been in elderly males, but in the literature, they actually mentioned that they tend to be younger. So maybe it might be like a variation in terms of which region of the world you're talking about, because a lot of the data that we that we get is actually from the US. The clinically important variants are morphiform or sclerosing basal cell carcinoma, including the keloidal variant, infiltrative or rather infiltrating basal cell carcinoma. And I just want to make a point here that because often people confuse invasive BCC with infiltrating or infiltrative BCC, and the two are not synonymous. Infiltrative or infiltrating BCC is actually a distinct morphologic variant of BCC, which has a higher rate of recurrence. So it's not just BCC NOS that's invading the dermis. Metatypical BCC is another important variant to keep in mind, which sometimes is also confused with basosquamous carcinoma. And this is because there is quite a lot of morphological overlap. In some books, they actually just lump them together. But in Whedon, he makes a distinction between metatypical BCC and basosquamous BCC. And actually, I must say, like from my experience, the two do look different. If you actually pay attention to the minute detail, you'll actually realize that they're not quite the same. Micronodular BCC is actually quite an underestimated variant because often the tumors I've seen in practice, they've actually been quite big tumors, particularly like on the face areas, and they can infiltrate quite deeply into the underlying tissues such as the subcutaneous and skeletal muscle, especially when they're located around the eyelid area. And they also have a higher rate of recurrence. And clinically, the morphiform BCC, as the name says, it presents in a similar fashion to like morphea. So you get like a scar-like lesion, even though I suspect in this particular image, there must have been a previous surgical intervention because there is a linear thing, right here. This is the most beautiful picture that I got from Bologna. I think actually it encapsulates the issues with morphiform BCC, the fact that they can actually just look like a non-specific nothingness except for the hypopigmentation. Because in this particular example, it doesn't really look particularly scarred or scar-like. Okay, and on histology, typical of morphiform or sclerosing BCC is this highly infiltrative cords, which comprise small basoid cells in a background of a densely fibrocollagenous stroma. And this is the keloidal variant of morphiform BCC. And the reason we say it's keloidal is because the collagen bundles are thickened, and that reminds one of keloidal collagen that you see in keloids. So clinically, the morphiform BCC, as I've said, that is poorly delineated and it can mimic a scar. They are highly infiltrative histologically, and often there's perineural infiltration, which is why they actually have a higher rate of recurrence. It's because often that perineural infiltration, you see it at the peripheries of the tumor. And clinically, because it's quite poorly delineated, it can be difficult to actually tell as to where the tumor starts and stops. And you find that the excision is actually very close or within the tumor itself. And this is an example of an infiltrative or infiltrating BCC, which is very similar to a morphiform BCC, except that the stroma in between, although it's induced, it's not quite sclerotic. And there's a micronodular BCC, which is characterized by small nodules. Some of them might even comprise only a few cells. And it's quite an infiltrative variant of BCC. This is a nice example from Bologna. You can actually appreciate the small little nodules. Metatypical BCC, this is what it looks like. Tumor cells are often slightly larger than your usual BCC cells. They've got pale cytoplasm. And commonly, this is seen following treatment with radiation. And as I've already mentioned, that it can be confused with the basosquamous type of BCC because some of the cells can look squamoid. So metatypical and basosquamous BCCs, they actually have a higher metastatic potential. So these patients actually have to be followed up quite closely. Now, with regards to multifocal superficial BCC, I'm just going to mention it here for completeness because clinically, it can actually mimic things like Bowen's disease, actinic keratosis, and it can actually even also mimic inflammatory conditions such as lichen planus like keratosis, psoriasis, and nummular eczema. And histologically, you typically see there's little nodules that are attached to the overlying epidermis, and they're budding into the underlying dermis. And there are spaces of uninvolved dermis or epidermis between the individual nodules. And I will show you why this is actually important. So if you take a punch biopsy, depending on how wide apart the nodules are, the punch biopsy instrument might actually be, or rather go between two individual nodules. So you end up with a scenario like this. So if the pathologist doesn't know what you're looking for, what the size of the lesion is, they might mistakenly actually report this as just a non-specific fibrosis and inflammation, which is actually not the case. However, if we know how big the lesion is, and if we have an idea of what's being queried, that's actually going to prompt us to examine multiple sterile sections, and often one actually will find those adjacent nodules within the biopsy. Then moving to squamous cell carcinoma, this typically presents as exophytic, keratotic, or crusted nodules. Sometimes they can actually form plaques, as in the picture on the bottom. Okay, I've already showed you this picture. This is a BCC that's ulcerated here at the tip of the nose, and there is a squamous cell carcinoma on the cheek here, a raised tumor with a central crusted or keratotic area. Sometimes the tumors are just flat and crusted, as in this case here, which was actually located on the scalp, particularly on the scalp of bald elderly men. You have to actually look closely at the scalp because often there are actually actinic keratosis and tumors there. And as I've mentioned, the clinical presentation is usually in the older age group. Males are affected more than females, and particularly patients with fair skin, sometimes patients with albinism as well. And this tend to be on sun-exposed areas on the scalp, face, neck, and extensor surfaces of the limbs. With SCCs, this is the typical histology. You get this infiltrative cords and lobules that are extending into the dermis with atypical squamate-looking cells and this keratinization. Then moving to the keratoacanthoma variant, which some people actually, they don't believe that it's actually an SCC, but it is actually a SCC. So it typically presents as a rapidly enlarging papule, which then involves into a sharply circumscribed crateriform nodule with a central keratotic center. And this happens over a period of a few weeks, even though it can be variable from 3 to 10 weeks. There are also some cases where it's actually been over a couple of months. And this is the early stage of a keratoacanthoma. And histologically, this is what you see. You get lipping at the periphery, and you've got endophytic or infiltrative lobules of well-differentiated keratinocytes. And typical of keratoacanthoma, there is a trichelamal type keratinization, which is basically when you've got keratin formation without granular cell layer. At the bottom of regressing keratoacanthomas, you will actually see this dense mixed inflammatory infiltrate. And with advanced regression, you end up with a lesion that actually it's not as endophytic as it was before, but there's prominent lipping at the periphery, and usually at the bottom there'll be fibrosis and inflammation. And with advanced regression, the lesions can actually end up looking a little bit flat and mimic lesions such as hypertrophic lichen planus, lichen actinic keratosis, lichen planus like keratosis, irritated or inflamed seborrheic keratosis. They can all mimic Ka showing advanced regression. And I think one important thing to just keep in mind is that multiple keratoacanthoma-like lesions with sebaceous differentiation can be a marker of underlying Muir-Torre syndrome. So if you get a report, or if you're the pathologist, reporting a thing that looks like keratoacanthoma, and you've been told that there are multiple of them, just keep this disease in mind. Now, I've included trichelamal carcinoma here because there's a debate as to whether they're actually follicular tumors or just clear cell variants of SCC. Some people, consider them to be just clear cell variants of SCC, but in the WHO, they are classified as follicular tumors. And also the reason I included it here is because it presents in a very much similar fashion to SCC. And often when one has reported this tumor, you get phone calls from clinicians, like querying whether the diagnosis is right or not. And I think the reason for that is that people tend to think that it's a very rare tumor, and it's actually not. But I'm not saying that it's very common either. The risk factors, they are very similar to SCC, and they also present in a similar fashion, similar anatomic distribution as well. But histologically, there are some slight differences, as you will see. So you've got deeply endophytic lobules. Okay, so unlike with your usual regular SCCs, tracheal carcinomas, they tend to be quite circumscribed at their borders, almost similar to how you see circumscription in some early lesions or late lesions of keratoacanthoma. But more importantly, the squamous cells tend to be pale. Usually there's a bit more atypia than one expects to see in your garden variety SCC. And you also get trichelamal type keratinization. And in some instances, you can actually see nice peripheral palisading, but it's not an easy sign to pick up histologically. The good thing is that the majority of the trichelamal carcinomas are actually low-grade tumors, unlike other skin adnexal cell carcinomas. And they've got low metastatic potential. I think in the past, plus minus 10 years, I've only seen one that had metastasized to a cervical lymph node. And for this reason, they're surgically managed in a similar fashion to squamous cell carcinomas. An important variant of SCC, I think, for histopathologists and clinicians to remember is the pseudovascular or pseudoangiosarcomatous variant of SCC. Now, this is basically a very rare variant of acantholytic SCC, which is often overlooked. Presents mostly in males on the head and neck area. There have also been some cases that were reported on the vulva and penis, oral mucosa as well. You get it in the breast. So this particular tumor has frequent recurrences and high mortality rate, which is higher than your usual SCCs. And histologically, what you see is this highly infiltrative tumor. At low power, you'll be struck by spaces which resemble vascular spaces. And at higher power magnification, those spaces are lined sometimes by cells that are actually quite spindled, which is not what one expects to see in an SCC. And there's a little bit of hobnailing because of the enlarged nuclear. So the cells will be sticking out into the lumina of those vessel-like spaces. And in some cases, these vascular spaces are actually filled with erythrocytes, which then mimics an angiosarcoma even closely. In this particular variant, or rather in this particular example, the lining cells were epithelioid, and it actually mimicked an epithelioid angiosarcoma. This is just an example that I picked up from a case report. This particular patient had a large tumor, and these little lesions around it, these are actually satellites. So these are not independent tumors. These are satellites of this pseudovascular or pseudoangiosarcomatous SCC. And as I've mentioned, the histology, it mimics angiosarcoma quite closely. However, the vascular markers such as CD31, CD34, ERG, they will be negative in this tumor, while cytokeratins will be positive. The main histologic differential diagnosis is an angiosarcoma, which is a much more aggressive tumor, so it's actually quite important to make that distinction. And I've mentioned, the usefulness of immunos. So in angiosarcoma, the vascular markers such as CD31, 34, D240, FLI1, and ERG will be positive. And just keep in mind that occasionally, especially the epithelioid variants of angiosarcomas, they can stain with cytokeratins. Now, this aggressive tumor, it has to be managed quite aggressively surgically as well, to the point where some people actually advocate for a 1 centimeter margin to get the whole thing out, because when it's excised closely, there's a higher recurrence rate. And the patients actually should be followed up quite closely, as there's also a higher risk of metastasis. And in the event of recurrence, some literature, they suggest that maybe there might be a role for radiation. Now, this particular case, this was a 41-year-old man who presented with a rapidly enlarging lesion in the vicinity of the eyelid. It's actually a consult. It was a consult from one of our colleagues. And this is a clearly cystic lesion, and you can actually appreciate the lining epithelium at the periphery and the bit of circumscription. But what's unusual is that there are also quite proliferative lobules of squamous cells in both pictures here. And when you go to high power magnification, there are areas where it's actually quite infiltrative, and almost going into the underlying skeletal muscle here. And in this high power magnification, there's significant cytolytic atypia. So this is actually not just a garden variety epidermoid cyst. This was actually a squamous cell carcinoma arising in a proliferating epidermoid cyst. And the reason I'm actually showing you this is because often people excise cystic lesions and sometimes they actually bin them and throw away the tissue, which is actually not a good thing to do because you don't really know what kind of lesion you're throwing away. It might be an epidermoid cyst, but other times there could be something else that's growing in that epidermoid cyst. Now, lastly, with regards to squamous cell carcinomas, I just want to highlight the importance of squamous cell carcinomas in scarring conditions. These are often related to burn injuries, dystrophic epidermolysis bullosa, and even some lesions of leprosy when they heal. The thing about these tumors is that they have a higher rate of recurrence, metastasis, and mortality despite being histologically well differentiated. And up to 60%, there's up to 60% mortality rate in some studies. So they have to be followed up quite closely, patients that have this kind of tumors. Now, with melanomas, the typical presentation of melanoma is, majority in Caucasian patients, mostly males, particularly the elderly. And this is what, you might see. There might either be flat lesions, as in this patient on the left. And actually, this image on the right here, Dr. Alex Border picked up this lesion on a patient who was admitted for something else, but she noticed that this lesion is quite irregular. And she, biopsied it, and there was actually a pre-existing nevus with a melanoma arising from that nevus in this particular case. And it actually quite helped because she gave us quite a nice history of the evolution of the lesion. This is just an example of a pigmented plaque, and there's variation in the pigment, irregular border, typical of melanoma. This was a tumorous lesion of a patient from Lesotho. I think this was actually one of the biggest lumps of melanoma that I had ever seen. Like almost the entire heel was actually replaced by this pigmented tumor. Sometimes you get little nodular things that are ulcerated, as in this particular case here. This was an acral lentiginous melanoma. Then with regards to histologic variants of melanoma, there is a lot of them as well. These are all, it's basically for us as histopathologists to recognize them so that we don't miss, the morphologic variations in melanomas. But for clinicians, I think the important one to actually really keep in mind is the desmoplastic melanoma, because there are other subtypes of melanomas. In terms of prognosis, it's actually the basal thickness that's more important and not so much the subtype of melanoma. And when we think of melanoma, most of us, we think of a big, ugly lesion histologically, like superficial spreading melanoma, asymmetric lesion like this with asymmetric pigment distribution. And this particular variant is verrucous. And at low power magnification, you often see irregularly distributed nests of atypical cells with a lot of Pagetas scatter and dermal invasion by atypical melanocytes, and there's a mitosis there. But sometimes what you get is this, a lesion that's actually quite nicely, circumscribed, looks quite innocent at low power. However, you'll actually appreciate that it's not quite symmetrical because there's a lymphoid infiltrate on the one side of it and or rather a lot of pigment on this side, whereas the other side, kind of looks okayish. And on this side, you can appreciate nice maturation. You've got superficial nests with cellular dispersion with depth of the lesion. The melanocytes are bland. Okay, but when you look in the area where there was a lot of pigment, the nests are a little bit irregularly distributed at the junction, and you've got a dense lymphocytic infiltrate in the deeper parts here. And when you look closely in that area, There are atypical melanocytes at junction there, and you've got atypical melanocytes in the dermis as well, quite a brisk lymphocytic inflammation. And this is PRAME, which we actually use as sort of like a handhold in cases where we are not quite certain as to whether is this melanoma or not. Like it's not a magic bullet, as in, like if it's positive, it doesn't always mean that it's melanoma, but it actually helps you. Sometimes it's negative, even in obvious melanomas, but when it does work, it can actually bail you out. And in this particular case, the atypical area, there was diffuse staining with PRAME, whereas the benign-looking area of the lesion is negative. And the clinician had indicated that this was a long-standing lesion which had changed. So we were happy actually to diagnose nevoid melanoma arising in a pre-existing compound nevus. So that's the melanoma there, and the bulk of this is actually just the nevus. So this particular case actually highlights the importance of clinico-pathologic correlation, which is why we would really like it if we can be provided with not just the age of the patient, but also the anatomic location. The reason being that some melanocytic lesions at certain locations can actually look ugly and mimic melanomas. So if we don't know where the biopsy is from or the excision, we might actually end up calling it melanoma when it's not. Knowing the size of the lesion also helps. And more importantly, the history of evolution of the lesion. Such as the change in size, the shape, and or color of the lesion. These are very important for us. Now, this is another lesion, which is typically or rather commonly mistaken for melanoma. But when you are familiar with the lesion, you'll actually know that it's unlikely to be melanoma just from the history alone. So, and the reason often clinicians might, they get worried about this lesion is that it's quite a heavily pigmented lesion. So they appear quite dark. And a lot of the pigment is in both the stratum corneum, the epidermis, and the dermis as well. When you look at this particular lesion at higher power magnification, there are nests of spindled or fusiform melanocytes. In some lesions, actually, you might even see a little bit of paginated scatter, usually towards the center of the lesion. And in some books, they actually describe this nest as resembling bunches of bananas because of the spindled or fusiform melanocytes. There might be a little bit of pleomorphism, as in mild pleomorphism. But when you've got the history, when you've got the history, then you know that actually this is just the reed nevus, which is also called the pigmented spindle cell nevus of reed. And it's actually a benign lesion. They're typically located on the lower limbs of young female patients. Often when you've actually seen one before, the next time when you see another one, it's actually very easy to spot. Again, this particular case highlights the importance of actually knowing the age of the patient, the anatomic location of the lesion, the history of evolution of the lesion, because often reed nevi, they don't grow rapidly to become big lesions. Okay. Another thing to just that's useful is actually knowing whether there's previous intervention. Okay, this next lesion, this was a 7-year-old boy who presented with a 5-year history of a lesion on the right thigh. And it's quite a biggish lesion, but it's circumscribed and relatively symmetrical. There's surface fibrin there because the lesion had been traumatized, so that's not an ulcer. And when you do S100 immuno, it actually helps you to appreciate the maturation of this lesion. You've got big nests at the top, and they get smaller, and eventually there is cellular dispersion with depth. And at high power magnification, the cells are schizoid. There's mild pleomorphism, but not severe. And in the deep parts, there is maturation cytologically and architecturally as well. So this is actually an atypical space tumor. And the reason we called it an atypical space tumor was because there was mild to moderate nuclear atypia. There was some mitosis, but there were few, and they were mostly distributed in the superficial parts of the lesion. So as much as we said it's an atypical space tumor, we favor it to be benign. And the reason being that we knew that it was a long-standing lesion in a child, and this particular child was actually a black African child. So it was very unlikely for it to be melanoma. However, we still mentioned that it would be prudent to actually just subject the lesion to molecular testing to confirm to confirm 100% that actually this is a benign lesion. So again, this particular case also highlights the importance of clinico-pathologic correlation, because knowing the age of the patient, the race, and the history of evolution of the lesion, we were actually quite comfortable to make a diagnosis of an atypical Spitz tumor, and we favored it to be benign. Now, this particular lesion here, this was a purely junctional lesion with a little bit of, or not a little bit, but actually fibrosis in the dermis with pigmentary incontinence. Okay. And the nest had melanocytes that were atypical, but note that there's no purgated scatter. But however, it was still worrisome because when you look at these melanocytes at higher power magnification, they're quite atypical. And in this nest here, there's actually 2 to 3-fold variation in nuclear size, which is actually worrisome for in situ melanoma. But if you step back and look at it from low power magnification, you'll appreciate that that fibrosis is not just confined to the subepidermal area. It actually extends quite deeply, and there's loss of skin adnexal structures, meaning that actually there must have been surgical intervention here. So this was a case of a recurrent nevus, or so-called pseudomelanoma. And they're called pseudomelanoma because of the fact that they can actually look quite atypical. Sometimes you may even see severe atypia and isolated suprabasal melanocytes. But with one caveat, that before you actually call this type of lesion confidently a benign nevus, you have to review the previous histology to make sure that indeed what was excised here was just the nevus and not a melanoma, because melanoma would look the same. Again, just this case here actually highlights the importance of actually having all the clinical information, knowing whether there was previous intervention at the site, incomplete excision of a lesion, partial biopsy. All of these things actually help us to arrive at accurate diagnosis. Now, with regards to partial biopsies of melanocytic lesions, some people do it, even though it's actually not the standard of practice. The reason being that such biopsies are actually non-representative, and they preclude assessment of architecture, which is a very important parameter for us to assess. And because of this, there's an associated high frequency of misdiagnosis. And I will show you why. This is that same melanoma that I showed to you, in the previous slides. As I mentioned, most of this lesion here is actually a benign nevus, and there's a melanoma arising in it. So if you take a partial biopsy, depending on where the biopsy was taken, yes, if you go for the darkly pigmented area where it looks a little bit irregular, like we will be able to tell you that it's melanoma. But in some instances, that darkly pigmented area, that could actually just be the compound nevus, and you find that the lightly pigmented flat thing next door to it, that's actually where the in situ melanoma is arising in that particular nevus. So punch biopsies or partial biopsies of pigmented lesions, they're actually not recommended for that particular reason, that there's a lot of misdiagnosis with them. Okay, just to wrap up with regards to the melanomas, is that it's important for us to be provided with the age of the patient, even though actually like this often we have just from the details that need to be filled on the form. The anatomic location of the lesion is very important, as I've mentioned, depending on the site. Some lesions can mimic melanoma. The size of the lesion is important. And the reason the size of the lesion is also important is the fact that if we know that actually like what we have, let's say you've taken a small or partial biopsy of a lesion, but we know you've taken a 3 millimeter punch biopsy of a lesion that's 3 millimeters, that actually helps us because we know that actually we've got the entire lesion. And it's also important to actually like provide us with a history of evolution of the lesion, because then we can actually make a confident diagnosis of a melanoma that's arising in a nevus in some of these cases. If there was previous intervention, it'll help to actually tell us about that. As I've mentioned, also like It's preferable that people do excisional biopsies, such as formal excisions, shave excisions, or what is called scissorization. Punch excisional biopsies are also like useful in small lesions. If you can excise the whole thing with a punch, so why not? But also, if it's a big lump of tumor on the face, and you can see that is overt or obvious invasive melanoma clinically, it's okay to actually take a punch of that because most likely we will be able to make diagnosis. Now, moving to the reporting of melanoma, there are some minimum criteria that need to be included in the report. And over the years, I have seen, like some reports which I actually thought they were not quite sufficient. So these are the data elements that are considered to be basically like minimum requirements by the American Society of Dermatopathology. The diagnosis, and that diagnosis should be put clearly that it's invasive melanoma. Things like tumor thickness, ulceration, tumor mitotic activity per square millimeter, neurotropism, lymphovascular invasion, cytolytosis, and staging. These are the core of what a melanoma report should have at a minimum. So if the report doesn't have all 9 of these, that's a substandard report. Now, with regards to those parameters, there are also some things to note. Things like melanoma subtype. Okay, the Americans, they are not as rigid about subtyping the melanoma in the report, and the reason for that is because the staging and prognosis is more dependent on the Breslow thickness and not so much the type of melanoma, with the exception of pure desmoplastic melanoma, because pure desmoplastic melanomas, they hardly metastasize to lymph nodes. So the patients with desmoplastic melanomas, they generally do quite well, except when there's neurotropism, they can actually be quite difficult to manage surgically. Even though it's not as important to actually subtype melanoma, but there are also some subtypes which are just important to just note in the report for certain reasons, such as nodular melanoma. It's important to note it because this conveys a message to the clinician about the need for clinical correlation about the primary nature of the lesion, because some cutaneous metastasis of melanoma, they can actually mimic primary nodular melanoma. So that's why it's actually important to just specify in that scenario. Spitz and Spitzwet melanomas, nevoid melanoma, and undifferentiated melanoma, it's important to mention them because this highlights diagnostic difficulty and the potential for a need for molecular confirmation of the diagnosis, because these are difficult melanocytic lesions to actually diagnose. Okay, regarding the Breslow thickness, so the Breslow thickness should not be taken at foci of periadnectal extension. The reason being that sometimes those melanocytes around adnexal structures, they actually do not arise from the epidermis, but rather from the actual adnexal structures in the vicinity. So whenever possible, should avoid measuring the Breslow thickness there. It's also important to note that in subepithelial nodular melanomas and melanomas arising from the deep parts of congenital nevi, the tumor thickness has limited predictive value. And the reason for this is that this is not a melanoma that's actually arising from the epidermis. But yet, when you measure the Breslow thickness, by definition, you're supposed to be measuring it from the granular cell layer. So it becomes a little bit difficult to actually get the Breslow thickness right. And that's why it's not as predictive in this particular types of melanomas. Ulceration is important to report because there's some people also mention that there's some value in actually measuring it because patients that have ulcers that are more than 5 millimeters in diameter, they actually do worse compared to those that have ulcers that are less than 5 millimeters. There are also some data which is non-core, but it's still nice to actually report because it still provides the clinician with some useful information. Things like tumor infiltrating lymphocytes, it's actually, it's a positive prognostic marker because it's telling you that the patient's immune system actually does recognize the melanoma and is trying to destroy it. Regression, it's an ongoing discussion as to whether actually regression alone on its own, is it actually like a positive or a negative prognostic factor? But it's still nice to actually just include it in the report in case the clinician needs it. Angiotropism and neurotropism, as I've mentioned, that like with desmoplastic melanoma, neurotropism sometimes it's actually right at the periphery of the tumor, and it makes it difficult to surgically manage the tumor. Lymphovascular invasion, if there is, or rather, actually, even if there is, it's rather just mention it in the report that there's no lymphovascular invasion. The reason being that when there is, it's actually associated with a higher risk of metastasis to the regional lymph nodes. Right, but not every malignancy that's in the skin is actually of cutaneous origin. This was a scalp tumor in a man of 56 years old, and it's actually quite an infiltrative tumor with areas of necrosis. And there was an infiltration of the skull here. That's bone, and that's the tumor around the bone. And the neoplastic cells were quite atypical with prominent nucleoli, and they looked almost plasmacytoid, and that's just necrosis there. And again, the cells had quite prominent nucleoli, and they kind of mimicked plasma cells. And on immunohistochemistry, there was positive staining with EMA, VS38C, which is actually a marker of plasma cell differentiation. CD79A was negative. Kappa and lambda, there was no restriction. S100 was negative, therefore it's not melanoma. MNF116 was positive, CK7 negative, 20 negative, and polyclonal as well as monoclonal PSA were positive. So this is actually a metastatic prostatic carcinoma mimicking myeloma. Now, the reason I'm showing you that is to actually just highlight the importance of actually, previous, or rather the history of previous malignancies. And whenever possible, it'll be useful if we are provided with a specific type of neoplasm, because this reduces the need for longer panels of immunoperoxidase stains, which actually saves the patients money. And also we can actually sign out the report quicker, because all we have to do is a couple of immunos, because we already know that this patient has prostate CA. So we can actually just, have tailor-made immunos for that particular case. This was a skin biopsy showing infiltration by carcinoma, which didn't seem to be of cutaneous origin. The tumor did stain with CK7. ER was also positive, which is estrogen receptor. It was positive with HER2. And this is basic cutaneous involvement by ductal carcinoma of the breast. But without knowing where the biopsy is taken from, it becomes difficult for us to actually say to you whether this is direct extension into the skin of a tumor that's arising from underlying breast, or is it a metastasis? Because this is all dependent on where the biopsy was taken. Now, the last part of my talk, I want to just talk about effects of therapy and tissue handling on the diagnosis of malignancies. And I will show you a few examples of how this actually affects the histology. This was a case of a BCC which was treated with Aldara, which actually explains why there was a dense lymphocytic infiltrate which extended into the dermoepidermal junction. There were also some dyskeratotic keratinocytes. And this particular histology, actually, it mimicked lupus. And when you do the Alcin blue stain, there will also be mucin. And if you have not been provided with the history, you might actually mistake this for cutaneous lupus erythematosus. Meanwhile, it's actually just lupus erythematosus-like reaction to Aldara. Okay, this was a keratoacanthoma, which was left, left out to dry a little bit, not intentionally, obviously, before it was actually put in formalin. And unfortunately, when we process tissue that has been left without formalin for a while, this is what you end up with. There is distortion of the architecture. I mean, you can still appreciate that it's possibly a crateriform lesion, but when you go to higher magnification, you actually can't see any cellular detail, which makes it difficult to actually say whether this is a well-differentiated, SCC of Ka type, or is it possible that only the upper parts of the tumor are showing Ka, and there's a poorly differentiated component in the deeper parts, which is something that we often see in lesions that were biopsied or excised as keratoacanthoma. Because clinically, the top part will look like a keratoacanthoma, even clinically, the lesion will look like keratoacanthoma. But however, on histology, you'll find that the upper parts do look like keratoacanthoma, while the deeper parts show poor differentiation. So in this particular case, one couldn't actually say whether this is just keratoacanthoma or is it like some keratoacanthoma like poorly differentiated squamous cell carcinoma. Okay, this is another lesion which was left to dry out a little bit on the table before it was actually put in formalin. Again, you can't, or rather the architecture is slightly distorted, but we thought this must be the lesion here, and we were happy that it seems to be a little bit circumscribed. We couldn't quite see what was in the epidermis. And when you go to higher power, you can appreciate cellular detail. Actually, the cells look almost spindled. Because of that circumscription, we favored this lesion to actually be a nevus, but unfortunately, this was actually a melanoma which recurred, and that recurrence was sent to another lab, and we were informed that actually that lesion that we reported a few months ago, it wasn't a nevus, but rather melanoma. Okay, this is another case of recurrent cyst on the cheek of a 56-year-old lady. This lesion was thought to be a cyst, therefore it wasn't submitted for histology because they thought it's an epidermoid cyst. But when it recurred the third time, then they submitted it for histology. And you can appreciate that there are atypical epithelial cells here, and some of them do have pigment. You even have big lumps of pigment here. Mitosis. Okay, therefore this was actually a melanotic melanoma and not an epidermoid cyst. So this was recurrence of the so-called cyst which was binned. So the take-home message here is that it's important to actually just provide us with the basic clinical information, things such as the relevant previous malignant diagnosis if the patient had a previous malignancy of sorts, the anatomic location of the lesion, the history of evolution of the lesion, particularly in pigmented lesions. This is very useful for us. And also the handling of the specimen. It's important to just note that this actually affects the accuracy of this histological assessment. And the last point is, I think often clinicians get reports from us that are substandard, and they're too shy to actually call the pathologist to actually say, what do you mean by this? Or why doesn't this report have blah, blah, blah? And I think that, clinicians shouldn't be shy about this because we are being paid to actually help you. So calling us to seek some clarity about our reports, it's the right thing to do. And actually that's what actually helps the patients. Because I've seen, reports where the diagnosis is actually quite straightforward, but the actual weighting of it, you find that it's actually quite ambiguous. And you get a call from the clinician saying, oh, I got this report from so-and-so, and I'm not quite sure what they mean, so I think people shouldn't be shy about this, to call the reporting clinician and just seek clarity about exactly what's being said in the report. And if you feel like the report actually it's insufficient, there isn't enough data to actually help you with the management of the patient, don't be shy, please. Just, call the reporting pathologist and say, well, usually in BCCs, this is what I expect. The report should have the subtype of the BCC so that I can know whether it's infiltrating, morphiform, micronodular, because that actually has an impact on how you are going to manage the patient and as well as a follow-up of that particular patient. Thank you.
Thank you very much, Dr. Tirelo, for the informative presentation. I do have a few questions, and I see we do have a bit of time. So we have a question. Are the pseudoangiosarcomatosis SCC radiation-induced possibly, or are the radiation-induced ones pure angiosarcomas?
The The pseudovascular or pseudoangiosarcomatous SCCs, they are not radiation induced. The mechanism behind the pseudovascular spaces is actually acantholysis. So it's a similar mechanism to what you see in ordinary acantholytic SCCs.
Okay, thank you, doctor. The next one, would UV radiation like welding or sunlight aggravate this form of cancer?
Sorry?
Would UV radiation like welding or sunlight aggravate this form of cancer?
As in the pseudoangiosarcomatous SCC?
Yes,
No,
I would assume so.
It shouldn't aggravate it. Actually, they recommend radiation for the recurrent tumors.
Okay, thank you, doctor. Okay, I know you have mentioned numerous times what specific information is relevant to fill out on a histopathology form. Sometimes, as clinicians, we do not always write down the correct information the pathologists are looking for.
Beg your pardon?
So I know you've mentioned this during your presentation numerous times. Someone is asking what specific information is relevant to fill out on a histopathology form. Sometimes as clinicians, we do not always write down the correct information the pathologists are looking for.
Okay. It's actually really basic things that we often take for granted. Just saying where the lesion is, that the exact anatomic site. I mean, some people try, but then they will write something like leg, and the leg is actually quite big. So the best thing is to actually say exactly where the lesion was excised, and also like the history of that lesion. Particularly in pigmented lesions, as I've mentioned, that it's useful to actually know for how long the patient has had the lesion. Has the lesion changed in recent times? A change in terms of its size, its color, that kind of thing. If it's not a pigmented lesion, but you think that this could be a malignancy, or maybe it's just some tumorous or nodular lesion. If you know that the patient previously was diagnosed, let's say, with breast carcinoma, it would be useful to actually make us aware that this particular patient had a breast CA diagnosis previously. The reason also being that sometimes that previous histology was not reported by us, so we wouldn't have access to that previous report. It may have been reported maybe at Lancet or PubCare, and we don't have access to their laboratory systems, so we can't check the patient's previous history.
Thank you, doctor. Another question. Let me just scroll here. As for lesions on the face and legs, is there anything that can be applied to help heal them faster?
As an applied topically, I would presume it depends. As a histopathologist, I'm not the right person to actually answer that kind of question, but lesions such as actinic keratosis, Bowen's disease, they can be treated actually with Aldaro. I'm not sure whether that question, that's what they mean.
Okay, thank
but
you, doctor.
you can't treat an invasive, let's say SCC or BCC with Aldaro. It's not going to work.
Okay, let me just see. What is the difference between neurotropism and perineural infiltration?
It's basically the same thing, but you can have two types of neurotropism. Sometimes with neurotropism, all you have is wrapping of the tumor around the nerve. Other times, you actually have the actual tumor infiltrating the substance as in the center of the nerve.
Thank you, doctor. Why does skin cancer affect most white males than African males?
It has to do a lot with genetics, the melanin, which is actually protective against UV rays, and that's why black patients that have albinism, they do get the same cancers, SCCs and BCCs. The only thing I don't have extensive experience with, or rather that I haven't quite noticed a lot, patients with albinism, they don't seem to get as many melanomas as white patients. Yeah, but a lot of it has to do with UV protection.
Okay, thank you, doctor. And then another question, specimens left without formalin, after how long was the specimen left that you see structural changes?
I can't tell you exactly after how long, but the ideal thing is as soon as you've actually excised the lesion, as soon as you've taken the biopsy, rather just put it in the formalin fixative immediately to avoid having that issue. I mean, a couple of minutes is not going to have that much of an effect. Sometimes even when we do frozen sections, we actually leave some of the tissue lying around for quite a bit while we're looking at other bits of tissue. But the longer you leave it, the more likely the preservation will deteriorate. A couple of minutes are safe.
Okay, thank you, doctor. And then another question, is there a relationship between occupational exposures and some of the skin cancers?
Some, I know if, people that actually work with arsenic does have carcinogenic effects. Occupation also in terms of if you're maybe somebody who actually works out in the outdoors and you're exposed to the sun most of the time, you are at high risk of developing skin cancers.
Thank you, doctor. Someone is saying, can you please share a small insight about meltums and how patient age and history of lesion might affect diagnosis?
Beg your pardon, Yolanda? Information about?
About meltums.
Meltums. Meltums, I presume they mean in the context of melanocytic lesions, whereby we send out the report saying, basically, it's a melanocytic lesion and we can't determine the biologic potential of it. What we mean in that context is that we are worried about the lesion, but however, there are also some features which are unusual, which actually are against the melanoma. So basically, it's when we can't say whether a lesion is melanoma or a nevus. And in those kind of scenarios, we recommend subjecting the lesions to molecular testing, because if the lesion does have melanoma-associated genes, then we know that definitely it is a melanoma.
Thank you very much, Dr. Tirello. We are running out of time, but if you have any further questions, please do post them in the chat box and we will attend to them after the session. Thank you very much for your time, everyone, and thank you for joining us. I hope you have a wonderful evening. Thank you. Bye-bye.
Thanks, everyone.